Hi, my name is Tony Tillotson from Cambridge University Health Partners, and I'd like to welcome you to today's Cambridge Biomedical Campus on Virtual Tour event. As many of our regular viewers know, CBC on Tour brings the best clinicians, researchers, and academics direct to your laptops, tablets, and phones as they explain the work sorry about that, I did that mistake last time. As they explain their work, challenges they face, and their thoughts on what the future of healthcare may look like. Following on from our last event with Professor David Rowich on Cambridge Children's, I'm really pleased to introduce Dr. Arun Gupta, who is going to talk about how he and his colleagues are developing the skills of our medical workforce. Aaron was appointed as a consultant in anaesthesia and neurocritical care at Aaron Hospital in 1996, and he was the director of Neurosciences Critical Care Unit for over 3 years before becoming director of Postgraduate Medical Education for Cambridge University Hospitals and the Aaron Simulation Centre. Aaron is amazing, is all I think his bio basically says. His particular field of research interest is in the effects of injury on brain tissue oxygenation and metabolism. Sorry. As usual, if you're watching through Zoom, you can ask questions at any time through the Q&A box, which will then be addressed at the end of the talk. We will do our best to include any comments which were made on YouTube Live, but please don't be too disappointed if yours is not included. And finally, to reassure you all, you won't be seen or heard throughout this event, but it will be recorded to be available on our website afterwards and on the YouTube site too. So without any further ado, let me hand over to Aaron.
Thank you, Tony, for that kind introduction, and also thank Jill Wilson for inviting me to talk today on CBC Online. So the subject of today's talk is training doctors in the digital age. It's a very wide subject, but what I'd like to do is talk about 4 main areas to discuss. For those who are non-medics, I thought I'd just introduce the process of how doctors are trained, then talk about some emerging issues around digital medicine, some of the training implications and leadership implications. And in the second half of the talk, talk about how simulation has been useful in the development of training, how it's helped with the COVID pandemic, and how it will help in the future in training our next healthcare workforce. And then at the end of that, I'd like to talk about extended reality and how that is coming into the healthcare workforce, both in clinical practice aspect, but also the training aspect as well. So just to give a very quick summary of how a doctor is trained. So a student will enter medical school for a 4 or 5 or 6 year program. A 4-year program is for those who have already done a degree, so postgraduates, and Cambridge has a postgraduate course. Most courses are 5 years in length, with a 6th year for an intercalation. The Cambridge course is 6 years mandatory. After that, after graduating from medical school, students are then going to a 2-year foundation program, which is aimed at obtaining and improving generic medical skills. At the end of the first foundation year, the General Medical Council would normally register the student as a fully fledged doctor, and then in completion of the foundation 2 year, they can apply for specialist training, either as a general practitioner, which takes 3 years, or as a hospital specialist, or other specialist, which can take, after a 2-year core training program, another 4 to 6 years. Then at the end of that program, once completion of training has occurred, then they can apply for consultant posts. There are 32 specialties and subspecialties in medicine. So for those of you who are interested, who are listening and interested in applying for medicine, it offers a broad range of specialties and opportunities. So I would encourage it tremendously. The training programs, of course, would vary in duration and structure depending on the type of specialist that you want to be. But the key point really is that it takes a long time to train a doctor, a minimum of 9 years for a general practitioner to a maximum of 16 years for other specialties, both tertiary, secondary and tertiary specialties. So any changes in training take a long time to filter through. Of course, the COVID pandemic has had major effects on the ability to train our doctors. And there's a whole host of reasons, but this is a list of some of them. And largely, there have been a redeployment of doctors and students to cope with the surge of COVID patients, both in hospitals and out in family care, primary care. That because of social distancing, face-to-face teaching markedly reduced, and it's really only just beginning to come back. And because of the predominance of COVID, there's been a lack of diversity of clinical cases. And of course, people have been either isolating or off sick, so the opportunity to get trained has been limited. It's impacted all specialties in medicine, but as this slide shows that the surgical training has been majorly impacted, and this graph here shows that in April 2020, there's been a tremendous drop in elective activity and elective cases, which are training cases from logbooks of surgical trainees. And that began to recover, but is still on the recovery trajectory. So access and ability to do surgical procedures and train surgical procedures has been fairly limited over the last 2 years. So how do we train the next generation and also the current generation of doctors who have been affected by a pandemic, in the context that there is an increased numbers of medical students coming through the system? There's still some restriction to access to training, although we hope that that will improve. And as we hear, there is a huge burden on the service to improve the backlog of patients who are waiting for treatment. As we all know, that once the pressures on service become excessive, one of the casualties of that is the training of our staff. And we need to make sure that the balance of service versus training is maintained, so that actually in future years, we have the staff who are able to deliver clinical practice. And of course, everyone in the health service has been under tremendous strain over the last couple of years, and we need to make sure that the work-life balance of people is maintained. So we'll see new models of healthcare coming in, and new ways of working. And when we train our future doctors in those new ways of working, we need to make sure we integrate those new ways of training and working with other professional groups. Many of you who work at CUH will remember the introduction of the EPIC system in CUH in 2014. It was a sort of a remarkable achievement of organisation, I have to say, in hindsight. But what it did for many of us clinicians was the first introduction in the concept of healthcare data. And what I'd like to talk about are two aspects of that. One is how we train people in the digital technologies and digital medicine that is evolving, and how we use technologies to help with service delivery, but particularly in this talk around training. So this was recognised by Eric Topol, who's a clinician in the United States, who was commissioned by the Secretary of State for Health and Care in 2019, delivered this report on how we should prepare the healthcare workforce for the digital future. And he identified 3 themes of technologies which affect the workforce, and that's digital medicine, genomics, artificial intelligence and robotics. And what I'd like to talk about over the next couple of minutes is around digital medicine. In his report, he published this diagram, which showed 10 technologies which would probably have the most impact on the workforce over the next 20 years. And the heat map shows that as the darker colour occurs as you go right, that has more impact on workforce than in the lighter colours. But what I would suggest is that we have come a long way in the last 2 years in acquiring and adopting technologies, and I expect that we've moved a long way, almost past the 2025 threshold already, and that's because of the rapid increase in technologies that are available, but actually the processes to enable us to adopt those technologies. And as we adopt those technologies, we need to be able to understand what these technologies are and how they fit in with clinical practice, and how they are evaluated, whether they are appropriate for clinical care and or for training purposes. But one of the key things is what the data that these technologies produce can derive, and also how we develop those data. So as data is going to be part of all our healthcare workers' lives, we need to make sure that we train people into using it and understanding it. And for our future doctors, I think that has to be embedding it in undergraduate curricula. And then I think colleges and specialty groups will need to decide how that gets embedded into postgraduate curricula as well. And the degree of understanding will be different depending on the type of specialty you're in. Some specialties are very data heavy and others aren't. There is some rumblings around Health Education England around placements in healthcare data, and that's both at the foundation level and the specialist training level. And of course, there are numbers of courses that are available, both accredited and non-accredited, or modular courses from the Digital Academy or from other institutions like ourselves for degree level education on healthcare data. And of course, there'll be targeted training for specific purposes, and genomics is a good example of one of them. And we know that on the CBC site, the genomics is very active in what they do. One of the things that Eric Topol did highlight is the requirement and necessity for good digital leadership. And he described 3 different levels of that. One is at a local organizational level, and that is primarily people like clinical information officers. Then there's board level leadership with perhaps chief clinical information officers, and then system leaders where they perhaps are embedded in newly formed integrated care systems, where they can horizon scan and advise on opportunities for investments and technologies to help the skills gap. So how do we get to pipeline clinical or chief clinical information officers? We need to ensure that there are enough people trained to do these jobs. And again, without going through the whole list of things, there are opportunities from the Digital Academy, from institutions to learn the knowledge base, but also there needs to be placements both in the NHS and perhaps in the private sector, which may help move things along. But what's useful is an evolving community of interested parties within the newly formed Faculty of Clinical Informatics. And that provides a group of people who are enthusiastic, who are interested, and who can develop clinical informatics forward in the years to come. In terms of artificial intelligence, the same issues really apply. There needs to be good leadership to ensure that, particularly for the training aspect of it, educators are trained in AI, and that those trainers actually interact with developers of AI technologies, so that the educational aspects are included in them, and so that they both educate people about AI, but also tackle educational challenges using artificial intelligence as well. And this is an example of how that might work. These are robotic arms being developed by a local company, and they embed artificial intelligence into their technologies. And what that allows to do is both improve clinical practice, but it allows feedback to the surgeons operating it to ensure that they can digest that feedback and improve their techniques going forward. This is another example of AI with endoscopy training. The newer scopes now have artificial intelligence embedded in them, and that works for both the clinical effectiveness, so ability to predict lesions and spot lesions, but also educate the operator as to what those lesions might be and what they might look like. So now I'd like to talk about some of the technologies and digital technologies that are used in training. Of course, we are all familiar with most of the commonly used technologies. So Zoom meetings, Microsoft Teams, remote online learning, streaming from operating rooms or clinics. The use of telemedicine has increased rapidly, both in secondary and primary care. And the challenge there is, how do we teach people how to run consultations from remote consultations? There are webinars and a host of platforms that can host material that are formed. An example of that is the one that Health Education England, East of England, have adopted, which is Panopto Bridge, where material can be developed and hosted for the use of anyone in the region. But what I'd like to talk about in a bit more detail now is around simulation-based education. And we know that simulation has been used in healthcare for many years. 1930s it really started. It still continues to be developed. And what simulation is that it allows practicing of procedural skill or procedures or skills in a fully instructive and interactive fashion, but in a safe environment. And this has been recognised by by various chief medical officers in their publications, the Safe Medical Practice in 2008, up to the most recent one by Health Education England, which describes the use of immersive technologies and simulation-based technologies for clinical practice and enhancing education. And what we're trying to do is to increase or upskill individuals to a competency level that enables them to practice a procedure or a skill to minimize risk to the patient and to optimize outcome. And it's important to try and find indicators of how skills are being improved. And this diagram shows that in a surgical trainee who's learning how to separate a gallbladder from surrounding structures, you can look at the number of movements that they make. And an inexperienced operator will make almost double the number of movements to an experienced operator. But after periods of training, the number of movements drops rapidly to the level that you might expect an experienced operator to have. So we know that practice and skill development can be done within simulation. What we still need to understand is how long, what the memory of that is, and how long those training opportunities remain at those low levels. How often do they need to come for retraining to maintain those skills? Health Education England have, in their report, have outlined the fact that both from a workforce point of view and a system point of view, that simulation immersive training actually improves outcomes in many in many aspects. So clinical effectiveness, patient safety, quality improvement, staff well-being, patient experience and productivity. So with the acceptance of simulation as a legitimate way of training, how do we do that? There are a number of ways of doing it. There is basic simulations, which actually can be as simple as talking to someone or role-playing with someone. Low fidelity simulation equipment, which essentially are plastic models. Many of us in the healthcare sector would recognize very simple models, or even just bits of tissue that or equipment that can be usefully used. Then there's medium fidelity simulations, which are very basic mannequins or box trainers or part task trainers. And then there's the high fidelity simulators, which are computer-driven mannequins that can respond according to interventions that have been happening. And for surgeons, the gold standard, I guess, is the use of cadaveric material, but that's very expensive and very faculty heavy. And of course, there are the emerging technologies that provide extended reality that we'll talk about shortly. So just a few examples. This is a bit of porcine tissue where surgeons are practicing their basic surgical skills in stitching and other things. These are some task trainers which allow practice for insertion of chest drains or taking fluid out of someone's back, or other practical procedures that are appropriate to the task trainer. This is a sort of an advanced task trainer with endoscopy simulator. There's two issues really to highlight here. One is that the haptics, the feel of how the endoscope moves in this trainer is apparently very realistic, according to our clinical director in endoscopy. But also the equipment used actually demonstrates is the same equipment used in clinical practice, and also gives us the outputs that are very realistic. These are the medium fidelity mannequins which are attached to a monitor, and these monitors can be adapted and changed according to the simulated scenario that is used. And this is a more complex high fidelity mannequin where responses can be adapted, changes in respiratory function or heart function can be made within this mannequin from a computer that's remote. And outputs can be kind of delivered to the monitors that are being watched. This is an example of how a simulation scenario might be watched by delegates in a adjacent room. So there are 4 cameras in the simulator center, and each camera is showing different angles of the scenario going forward, including watching what's happening on the monitors. One thing that's emerging is that as technology improves, is the ability to remotely and stream and deliver interactive training. So this is a clinician who is wearing a very simple pair of glasses, tiny addition to the specs, which actually obviously is a camera that streams to anyone in remote locations who can be logged on. But also what's very useful is that any interaction from the students or questions from the students can be beamed into this screen here in the corner of the eye, and he can interact with the students that are remote and can adapt the training process according to what's required. So in terms of extended reality or XR, there are 3 main aspects to this. There's the most commonly used extended reality is virtual reality, which immerses users in a fully digital environment, and you need a headset or surround display to do that. Then there's augmented reality, which presents digital information, but also objects and media in the real world, and it can be used through a mobile device or a headset, and it can either be 2D or 3D. And mixed reality is really enhanced augmented reality, where the digital objects can exist in 3D, but also they react or interact with the surroundings around them. So that you can be in an operating theatre, for example, or a clinic or an emergency department, and have projected 3D images working to the benefit of the teaching programme. So many people who are familiar will be with headsets. The sales of headsets over COVID for gaming has gone through the roof, apparently. So this is familiar territory for many people. Within the VR headsets, there is software that you can choose your simulated scenario. So these are an example of 3 of them. The student can log on to the, this one, for example, is a 64-year-old man presenting for to the ED with vomiting. And within his screen, he will see a image, one of these, not all 4 of them, obviously. And as they interact and make interventions, those images will change according to the scenario and how it develops. Whole host of scenarios that are available. Many of them are adapted from the simulation scenarios that we've been using for a number of years. And the sessions or teaching sessions can be delivered in a number of ways. So group sessions with facilitators, open access and drop-in sessions, or even distance learning. The group sessions can be where a group of students get together, all wearing the headsets, as well as the faculty. A simulation proceeds, and then feedback can be gained from the students, both individually and as a group, as well as a faculty member. The open access is where a student can come, pick up some of the VR equipment, don't need any faculty to be available. They can choose a simulated scenario they want to work on, and get back, once complete, get some standardized feedback so that they can digest that and, if necessary, repeat it if they wish. But I think what's really useful is the ability to do this from a distance. So one can take some equipment home, so the headset home, or to wherever the student wants to do the training session, download the software, and then do the simulated scenario from a distance. Obviously without faculty, but it allows 24 hours unlimited access, and you can do it where and when you wish to. So with virtual reality, as technology improves, there is virtual reality simulators with haptics. And haptics is the ability to get feedback from feel and touch. So, for example, this scenario here is a surgeon trying to practice a cataract operation, and within that simulated environment, the haptics would be giving feedback to them to ensure that they get the right feel of tissue, etc. That technology is improving. It's still in early days, but I think will be quite important in time to come. So augmented and mixed reality, as you can see here, you have a two-dimensional image based in the clinic that you might be in, or a 3-dimensional image with the surrounding that you wish to have. And so that's augmented and mixed reality, which again we'll talk about shortly. So one of the technologies that are being acquired in many institutions, and it's being supported by Health Education England, is the adoption of these headsets called HoloLenses. They're made by Microsoft, and what they do is they allow immersive 3D content to be viewed and examined, and particularly useful in software that projects anatomy. So this is an image of what people might see with a HoloLens on. They can select the muscles and would get an image such as this. They can learn where the attachments are, how they move, what the structures of the bones are when the muscles are either there or not there, and if necessary, take off the muscles and look at different structures like the vasculature in 3D, and examine the anatomy in more detail. As well as that, they can look at different structures within the body. They can look at the heart, and they look at and sections of the heart and how that might what the anatomy of that is. So the the ability to look at anatomy in these sort of software is tremendous, and the prospect of doing this with other structures and other softwares are something that we are very keen on in looking at. Our colleagues in Imperial have used this technology to set up a biopsy intervention simulation where the biopsy needle can be traced through the CT scan that's already overlaid, and as the needle goes in, the HoloLens can actually track where that needle is. So it allows learning for practical procedures. The setup is always there, so someone can come and use it whenever they are available. It also allows, because of the 3D abilities and allowing the 3D imaging to be university seen, it also allows various different aspects of clinical practice as well. So this is an example of the pediatric heart. So CT scans have been reconstructed of this heart, and there is a plan to do surgery on this heart. And because the 3D image is available and you can see it in different slices and different aspects, faculty can actually discuss it from various locations. So this is an example of a pediatric surgeon at Alder Hey discussing the case and looking at the heart with a colleague in the United States, and determining how the best approach to treat this patient might be. So it both gives you real life images in 3D, but also helps remote consultation and learning with faculty members elsewhere. So I think, I'm hoping that this has allowed us to understand that extended reality allows replication of various scenarios, and the advantage of this is the 3D aspect of it in the location, real life location. That streaming allows widening access of and opportunities to remote learning and remote locations. And because of that, it would allow improvements in the standard of training that occurs in a more wide area. So inequalities of training hopefully will reduce. The evidence of the use of extended reality compared to other forms of training is still embryonic, I would say. There is some evidence that in laparoscopic training simulators with haptic feedback, surgeons improve their performance with extended reality compared to other digital methods or traditional methods. There is some evidence that student motivation and training is greater, but that may be a self-select group. And then there might be more effective post-interventions than traditional digital education might already have shown. So early days yet for the use of extended reality, but certainly interest is increasing. And I think the long and short of it would be that there'll be hybrid models of how people are trained. By, for example, if you are going up the surgical training curve of a procedure, you start with some basic simulation facilities like a tissue or part task trainer, then going up to augmented reality as you get up the skills curve, and then towards cadaveric training, and then to live patients. And different areas, different places have different solutions of how they're using these technologies. The clinical school here in Cambridge have used artificial intelligence and virtual reality, largely at Papworth, but also some at Addenbrooke's, to help train their students. Various different online teaching has been used, streaming elements where appropriate, and platforms as appropriate. So again, a hybrid type model of using various different forms of simulation and extended reality. So what's the future? Well, I think as technology improves, the utility of these things will improve, and our understanding and ability to use them will improve. One of the things that we do desperately need if we are going to use extended reality is really sound internet and 5G networks, and as that occurs, that will help the speed and the utility of the equipment and technology. There's the emergence of the tactile internet, which may occur once 5G occurs, so someone can practice a procedure from a distant location with robotic surgical equipment at the site. And then there's development of scenarios using holographic patients that we are helping a software company develop, which may actually be very useful for both undergraduate and postgraduate training. If I could, I would show you this video of the holographic patient, and hopefully we'll try that in due course. But thank you for your attention, and I'll take any questions.
Thank you, Aaron. That was a fascinating talk into kind of into the work that you do and what people are looking forward to. We haven't got any Q&As have come through from the audience yet, so if you have any questions, please put them in the Q&A or in the chat. I'm more than happy to put them to Aaron. But we have a couple that have come in beforehand, so if I start with those, it's probably the best way to work it through. So the first question that came through was, do you think the development of the metaverse will positively or negatively influence the adoption of medical technologies?
So I think, the metaverse, we're not there in the metaverse in the NHS yet. I think the mixed reality technologies are beginning to get there. But I don't think it would have a negative effect. I think it would have a positive effect, in that it will enable us to test out things in a more realistic way, and it'll sort of enable us to adopt more technologies as the metaverse sort of gets evolved. So I don't think it'll be a negative effect. I think it'll be a positive effect. I'm not, putting my hand to my heart, I'm not sure when and where that will happen, but it's something for the future, I suspect.
For those who aren't kind of afraid, and I think I was when I first read that question about the metaverse, thinking it was something to do with Marvel and Spider-Man and Iron Man and all that sort of thing. Can you kind of explain what the metaverse means in this area? Well,
it's something that is still for many of us is still in evolution. It's the ability to be in an environment that you either want to play in or you want to be in, and as I say, the mixed reality type of software actually allows us to get towards that.
Okay, thank you. I guess one of the questions I would have is, how real does the kind of virtual reality simulation feel? Are you talking about the haptic responses? What's it? It might be difficult to kind of say, but how different does it feel from the real thing?
So, particularly with sort of procedural skills, I think it depends on the sort of type of trainer there is. I mean, the technology is improving without a doubt, and the haptics are getting better. But if you talk to surgeons, training on task trainers, or even cadaveric material, which is not fresh frozen, doesn't have quite the feel or the touch of the real life. So I think we've come a long way over the last decade, and the emergence of engineered tissue may or may not be coming in, and there's lots of work on that within engineering, and I think that will help bring that haptic feedback closer to reality, but also the equipment for haptics will improve as well.
you. So there's loads of questions now coming in the Q&A, which is great. So first one is, have you measured the reactions of the general public to these novel training methods? The person who's asked the question said it might be important to gain public support to ensure that the adequate public funds are allocated to this field.
Yeah, so that's a really good question. I think if we're talking about extended reality, I expect we'll see the use of it in clinical practice more and more. So there are examples where it's been used very successfully in mental health, to improve mental health, in pain management, and other areas. So as we see technology improve, as we see people sort of understanding how it works and then applying it in the clinical practice, I think people will inevitably see this as they come into in their primary care, general practice, or into hospitals, and then that will probably, I suspect, will increase the acceptance of this. But to the direct answer the question is, we're just bringing in this technology to see whether it's usable or not. Certainly, the virtual reality stuff is. And that's become more widely used, but we haven't particularly engaged the public in seeing how we use it for training. But I think it's probably a very good point to make.
The next question was, what are your thoughts, and actually something that I was going to pick up with you about in terms of inequalities, because someone said, what are your thoughts on the need for expensive equipment to access the mixed reality learning environments, which could potentially increase educational inequalities?
Yeah, that's a really good question. And I think one of the exciting things about these sort of technologies is the ability to train large numbers of people in remote locations. There was an article came out late last week from UEA, University of East Anglia, where all their medical students have got headsets, VR headsets. I think, that's the direction we're going to travel in. In terms of mixed reality, I think as the technology improves, as people become more accustomed to it, the price of those will come down, and the utility will be more circumspect. So I don't think it'll be appropriate to use in all types of training. As I said at the end of the talk, there'll need to be a hybrid. But certainly, as they are now, the mixed reality headsets are quite expensive. They need to be used in an appropriate way that engages as many people as possible. But also, we need to put pressure on manufacturers and institutions like HEE to make sure that they're funded appropriately.
Okay, thank you. And do you think people feel comfortable with the kind of using virtual reality, the headsets, the online training? I'm kind of mindful of the experience that lots of school children had during COVID, of kind of learning in that kind of in an online arena, and the challenges that posed for them. Is that similar challenges which people find that they experience as part of this work?
So I think, to be honest, many people of certain age groups find it more challenging than others. I'll give you a good example. One of my colleagues, who's a intensivist colleague, who's been doing a lot of work on the HoloLens, took it home and gave it to his 9-year-old to put on his head. And within about 15 minutes, he was like using it as though he's been using it for years. It took us about 3 hours to get to that stage. So I think the new next generations are going to be more used to this sort of technologies. It won't phase them as it does others of a certain age. So I don't think that will be a problem in future. I think, and also I think technologies improve. So the headsets will become less heavy, less intrusive, etc.
One of the I guess the links to that is, how do you then help if the younger generation are, as my children are, much more adaptable with new technology, how do you help those who are older to learn new things? Is it just a kind of case of, I don't want to say persevering, but kind of explaining, go through the process of explaining why?
Yeah, we saw this with with the introduction of simulation about 10 or 15 years ago. Often the more senior you were, the less likely you were to be wanting to engage in a simulated scenario. But over the years, that as people train and some retire, and people get used to the whole concept of these sorts of technologies. So I think it's a real issue about how we train the current generation of clinicians, and I think the future generations, will be less of an issue. But I think that the way to do it is to expose them to it, to make sure that it's not used in a critical way. It's used for development, etc. And a supportive method of learning.
Now, I may pronounce one of these words wrong, so I do apologise. So someone said, excellent talk. Thanks, Aaron. What may be the potential of mixing cadaveric stimulations with VR and MR motion takeaways without current haptics? And what's the potential cost implications for courses and attendees? Hopefully that makes sense to you.
Could you just repeat that? So I missed the sort of crucial.
Oh, what may be the potential of mixing cadaveric simulations with VR and MR motion takeaways without current haptics?
So okay, so that's something actually that we are hoping to work on. So the overlay of anatomy or whatever to using the software that things like AR and VR use is actually very possible, and I think in due course that's the way we will be sort of heading in that direction. But I don't think we're there yet. It takes a bit of technology to generate those sort of images and abilities. But I think that's a direction we do want to travel in, and I think the question is, will it make it excessively expensive? I think if we can, if it's very usable, we would want institutions to sort of use it and perhaps fund it from various sources like Health Education England or others.
Lovely, thank you. So next question, and this is probably, it may be this is not something that we can discuss properly in this talk, but someone's asked, how are we tackling the lack of doctors, nurses and other medical staff? I think clearly there are challenges which the NHS and government and sorts of institutions will be looking at to try and help. But how, I guess, can we, through new technologies, new ways of learning, help to reach out for and kind of try to meet some of the capacity restraints that we've got at the moment?
Yeah, I mean, that's a really good question. And that's sort of a subject of a very long discussion. But I think in the context of this talk, one of the ways to speed up training and get people through training processes, whether it be doctors, nurses, AHPs, is to use technology in an appropriate and logical way. So, things can be, if, for example, another pandemic or another variant comes and we are restricted in ways we can teach, we can do those things more remotely. We can, people can still have those learning experiences to make sure that they're trained at the end of it. I think we need to make recruitment more attractive, and this is work that's going on in integrated care systems now as major priorities of how we recruit and more importantly how we retain. And one of the things that we do see is that if we don't educate and train our existing staff, they just leave, and we need to make sure that we use these technologies to help educate them. As I said, there are there is evidence of positive experience after using these technologies. So the learning experience is better. And if we use these, we can help, train our people and then retain them rather than have them just leaving.
Thanks, Aaron. Next question is, all the haptics, etc. sound brilliant, but will the digital training methods be able to train on interpersonal communication skills too?
So, yeah, I mean, I think it's not all about haptics and not all about procedures. I think, some of the key simulation scenarios are going to be around, non-technical skills, essentially. And hopefully the person asking the question may understand what non-technical skills are, but largely they, as described, they are skills that are around communication, teamworking, etc. And I think, the virtual or the extended reality technologies might help in being able to deliver that both in face-to-face, but also more importantly, probably more remotely. So you can reach out to more people and further afield in these non-technical skills than we probably can do now.
How does that kind of build on to create better leaders almost in healthcare? Because that's one of the challenges that people will obviously have, that some will decide that their focus is going to be on surgery, but how do we take the people who want to develop their careers and help them with those leadership challenges?
So it's something that the NHS Leadership Academy have been very active in trying to develop. And ourselves on the CBC side, we've been fairly active in developing clinical leaders. I think there needs to be a recognition, as Topol has done, that leadership is very important in specific areas. And that we need all types of clinical leaders, be it they be doctors, nurses, or allied health professionals. And we need to make sure that we train them appropriately to be armed with the appropriate tools to be able to do that leadership process. So how are these technologies going to be able to do that? Well, for example, we have simulated sessions on management scenarios, which we use in leadership management courses. We can generate different scenarios using virtual reality if required. But I think what we need to make sure is that these are tools, and they're tools for the benefit of training. And what we shouldn't be focused on is we've got this tool, so we have to use it somehow. So I think in terms of leadership training, I think it's recognised that that clinical engagement actually increases or improves clinical outcomes. So that being recognised, I think leadership training should be supported by trusts and primary care CCGs for their training purposes, and not necessarily, but using extended reality wherever appropriate, but not necessarily exclusively.
Thank you. How do you feel Cambridge's position is, and actually the county's position is, compared to others around the UK? Are we, do we face challenges which other areas do? Is there anything different here? What can we learn from other areas? Is there anything that I would assume, and sorry if this is me being a bit naive, but there is interaction between different kind of training centres of excellence?
Yeah, I mean, so I think there's two things there. One is an interesting sort of fact that on average, the east of England is under-doctored by some significant degree, and we hope that, and there is work ongoing to repatriate medical training posts to the east of England, and perhaps the levelling up agenda will help with that process. But to answer your question around other centres, there's very good communications between ourselves on the campus, but also, so that's within Papworth, Addenbrooke's and CPFT, but also with centres around the county. So, places like Norwich, King's Lynn, West Suffolk, Peterborough, we all sort of have networks together that to talk to each other about certain programs that we run. Very often it's sort of centred around Health Education England or East of England, who do a pretty good job in helping coordinate these things. But I think you're right. I think in terms of this new technologies, it will be silly to concentrate to have expensive technologies in all sectors of the county, when perhaps we can just have them in one or two areas. And because of the the ability to train remotely, we can train in remote areas or outside within and outside the county from specific centres.
Great, thank you, Aaron. I think we've exhausted all the questions now, which is great. So thank you for everybody for joining us today and for providing the questions. And obviously, especially to you, Aaron, for your time. It's been fascinating learning about what's coming up and what's been done. Our next CBC talk will be on the 9th of March with Professor Paul Fletcher from the university, who's a psychologist there, who will be discussing his ongoing collaboration with local games company Ninja Theory. We also have the start of the CBC Wellbeing campaign entitled The Science of Eating, which we're doing in partnership with the Quadrum Institute in Norwich, and that will run on alternative weeks starting from next Tuesday, the 15th of February. All further details of how to register will be available via our social media channels and also through Eventbrite. It just leaves me to say thank you again, Aaron, for your time, and also to wish you all a lovely rest of the day. Thanks very much. Goodbye.